All right, did you?
Good evening, everyone. Welcome to Virtual Shadowing Session 69 with Dr. Fowler. Tonight, we will be discussing medicine, the path, and the journey from Dr. Fowler's point of view. Next slide, please. Here we have our working group, which consists of many undergraduate students and recent graduates, some of which have left us for medical school. And on the right, we have our faculty directors, Dr. Fowler, Dr. Salazar, Dr. Morchetti, and Dr. Reno. Next slide, please. Our upcoming sessions. Next week, we have Getting into Medical School 101 with Kyle Langston, who's a second-year medical student at UT Southwestern in Dallas. And during COVID, he decided to write a book on some tips and tricks on getting into medical school. So you definitely do not want to miss that one. Following that, on 9/28, we have Chasing My Cure, Physician, Scientist, and Patient, which is a best-selling author who's actually going to be talking with us. And on October 5th, we have Trauma and Acute Care Surgery, which is the original presentation that was supposed to be today, but unfortunately got rescheduled till then. Next slide, please. If you've never been here before, we have two Q&A sessions, one in the middle and one at the very end. Please feel free to type any questions that you have in the chat, and we'll have some of our working group members file through and sort out which questions Dr. Fowler will be answering. Next slide, please. And without further ado, Dr. Fowler, please take it away.
Well, good evening, everybody, and thank you so much for coming. It is always just an unestimable pleasure for us to be able to be with you. This is over 15 months that we've been here. This is what, Aditya, the 69th lecture, is that right?
Yes, sir.
And this means a great deal to us to be able to be part of your lives as we help guide you in your healthcare pathway, whatever that is, whether it's med school, nursing practitioner school, PA school, any kind of tech along the way. And what we're going to do, and anyway, to finish that point, we're so glad to have you. Again, if you keep coming back, we're going to be here. The crowds seem to be thinning a little bit. But I do want to tell you, and please pass this along to your health professions advisory councils, our admissions committee season has started again, and we're seeing lots of people who are applying, who are including virtual shadowing hours on their applications. So we're certainly seeing this showing up in the medical school applications realm. I have heard from at least one other dean of admissions that they don't care where the shadowing hours come from, which includes virtual shadowing hours. A student that I worked with the other day called it e-shadowing, which I thought was kind of cool. So anyway, if you keep coming back, we're going to be here. We're looking for grant funding to continue to help us. It costs us, a little under $10,000 a year to put this program on. We're not asking for anything, so we're going to try to get some grant funding to help us to continue this. And so with that, I wanted to talk to you a little bit person to person here and give you a straight face about what you're getting into. And to do so, I'm going to talk a bit about my path and my journey, but what I've learned along the way that I've found very, very helpful. There's a wonderful little book called Hiroshima by John Hersey. John Hersey went over to Hiroshima right after the bomb was exploded on August the 2nd or 3rd of 1945, in which 100,000 people were killed in the blink of an eye. This being the terrible tragedy of war. War is a horrible thing. The history of humans is fighting with each other. There were two major world wars in the last century alone. But the bomb ended the war between the Americans and the Japanese. And so Hershey went over there to see what the effect was on that city with the atomic bomb having exploded there. And of course, it destroyed the center of the city. There was a physician who was a family medicine physician who had been very successful prior to the war, who had done very, very well, who, when the bomb exploded, he was in his office was destroyed, and he barely survived. There were hundreds of thousands of people who left the city, getting out of the city, and it was a terrible disaster. And slowly gradually, steady, the side of the city was cleaned up and gradually, kind of sort of like what happened at 9/11 in New York, that it was cleaned up and finally rebuilt. I know the scope of 9/11 was nothing like what happened in Hiroshima. And this family medicine physician rebuilt his practice. And with the passing years, he was very successful. He did well. He was a very, if you know the words, bon vivant, very celebratory kind of individual, loved his life, and went on to do very well. And then finally, and then Hersey goes back and revisits Hiroshima a decade later, and then 10 more years later, so up to about 20 years after the bomb. This family medicine physician had done very well. He loved his life. He was really celebrating, enjoying life. And he went to Tokyo for a visit where he was visiting medical friends there, and they had a new hospital there with all the latest equipment. And so they said, well, you are an Akabusha, you are one of the survivors of the bomb. Why don't we give you a complete, thorough, total physical from top to bottom and see what we see? Because they knew that the incidence of cancer was much increased after the radiation exposure for the survivors of the atomic bomb. And so they examined this fellow and sadly found a mass on his left lung in the medial aspect by the pulmonary hilum, which is the inside of the lung where it joins the heart. And they said this absolutely distinctly could be cancer. We need to operate on you. We need to take this mass out. And so he said, well, made the decision to go ahead and have the surgery. And he did. And the lung was removed. The vessels inside where the lung had been were stitched. And he went off to recovery. Not too long while in recovery, after the surgery, one of the stitches came off one of the vessels that was sutured, ligated in the man's lung, and he began to bleed to death. He was in terrible physical condition, in deep shock, hemorrhagic shock, and there basically seemed nothing that could be done. The repair was made, but the man was still desperately ill and was lying on what he felt was going to be his deathbed. Presently, he began to improve, but his energy did not improve. He felt absolutely horrible. And he said that he really just wanted to go ahead and die. And one of his family members came to him and said, you know, in Japan, as a physician, you take an oath to the people that you serve. And that oath is that medicine is the art of compassion. The family member said this to him at that point to say, why aren't you showing the same compassion for yourself? The man, the physician, the patient heard this, and he thought greatly about it and slowly got his courage back, showed the compassion for himself, and finally began to recover. My first message to you tonight, folks, is that there is only one reason to get into any aspect of medicine. And I'm going to use medicine broadly. Medicine includes nursing, PA school, being a tech, and so forth. It's all the issues that have to do with people dealing with their issues of healthcare, number one, and the fact that they are terrified, which is the opportunity to help humanity. Ladies and gentlemen, the 200 plus of you tonight, do not get into medicine unless you believe that medicine is the art of compassion. I want you to, all 200 of you sitting where you are, say that aloud with me now, including the working group team. Ready? Medicine is the art of compassion. What you are doing when you're dealing with people who are ill is that you are doing a mix of two things. You are learning an applied science, wherever that field may be, medicine, nursing, and so forth, medicine broadly. And you're doing it because you want to give your compassion to others. You have to have both. I ask you all to look deep inside of yourselves right now and look inside yourself. Do you feel honestly that compassion for other people now? Aditi, I'm just checking. Is the network okay? Can you hear me okay?
Yes, sir. You sound
Okay,
great.
fine. I'm running two computers just in case, and the other one just died. So ladies and gentlemen, please look inside yourself, and on an ongoing basis, number one, ask yourself, do you have that compassion? A true drive to be involved in the lives of others, to learn an applied science, express that applied science for the purpose of benefiting their medical condition, and to be able to reach inside your heart and open your heart to others. You must ask yourself that. And when the time comes, in front of other interviewers down the road, somewhere, you're going to have to be able to express that. Because, folks, compassion asks us to go where it hurts, to enter into the places of pain, to share in brokenness, fear, confusion, and anguish. Compassion challenges us to cry out with those in misery, to mourn with those who are lonely, to weep with those in tears. Compassion means full immersion in the condition of being human. So, where did I come from? I'm a native of Western Georgia, about 30 minutes west of Atlanta, on I-20. I grew up on I-20, Interstate 20, west of Atlanta. I then went to medical school on Interstate 20. I went to University of Georgia, which was not on 20, then Medical College of Georgia, which was on Interstate 20. I did surgery briefly. I then began emergency medicine full-time in 1978 in Augusta, Georgia, where my medical school was. And then I went back to my hometown to practice medicine in 1980 for 20 years, also on I-20. And then I moved here 21 years ago and became faculty at UT Southwestern Medical School, where I am professor and chief of the Division of Emergency Medical Services. And I'm the Atkins Distinguished Professor of Emergency Medical Services. And I need to point out, Dallas is also on I-20. When I was home back in Georgia, I ran 4 emergency medicine groups. I built an urgent care center, which I ran for 20 years. I had my own billing company. I helped establish a national emergency medical services organization. I was part of the founding group. And initially, I was very much self-taught along the way. And now it's so funny that they let me be part of a formal emergency medicine residency training program and emergency medical services fellowship program as faculty. And it strikes me, and I encourage you to think about this, there was a marvelous scientist, writer, geologist at Harvard, evolutionist named Stephen Jay Gould, who just terrific writer, wonderful speaker, scientist. I flew from Atlanta one time just to hear him speak at College Station, Texas, because I'd followed him for years. Stephen Jay Gould said this. He said that the tape of life, think cassette tape or videotape, I know we don't use those anymore, the tape of life, if rewound, would not play the same way a second time. And what he was saying is that there are just too many coincidences in life. And I will tell you, my life has been absolutely packed full of coincidences. And if things had gone a different way, to start with, I would not be here with Aditi and all the rest of the team talking to you tonight. I would be someplace else. And so you must realize that coincidences are going to happen and to embrace them when they happen. Never find yourself that you don't have the courage to proceed forward, because generally speaking, if you go down a path and you find that you don't care for the path that you went down, that you can always reverse or turn a direction and go a different way. So I want to ask you, Why in the world go into medicine? Again, medicine broadly, medicine, nursing, PA school, and so forth. Well, the journey to medical school or any path into medicine, who among you should try this path? Firstly, you have to look inside yourself to see if you have a true compassionate feeling for others. Excuse me. If you don't really feel that you have that, it may be that you will develop it. I did over time. I can't say that I was a super compassionate person when I was young, like these kids that I'm working with. Kid is a compliment on the working group and many of you. But I have to say that having developed learned the applied science along the way, and then been cast deeply into being directly involved with helping people who are terrified and ill, I have to say, speaking personally and the way I view myself, is that my own personal elements of compassion have advanced and grown and strengthened with the passing years. I'm a single guy. I'll be 69 in a couple of months. I never got married. There were people along the way I should have married. Never had kids. My next older brother, who's an attorney, has 15 grandchildren. He's a year older than me. I never had kids. So just for me, I'm telling you my story. I very much got married to medicine. I say that she's been a jealous mistress, but I keep coming back to her. And for me, honestly, and being in perfect candor, the most social thing that I do is my work in medicine. I thoroughly enjoy this. And so I'm be 69 soon. I'm board certified in my specialty for another 8 years, which takes me to age 77. I plan to keep working. So the issue for burnout, which we'll get into in a moment, doesn't really apply to me, but that's because of my path. The type of life, if rewound for me, would play a different way. The second reason is work ethic. Folks, medicine is hard work. Medicine, again, broadly. Whether you're in high school or in college now, wherever school you get into that's your path, folks, it's going to be really hard. Using medical school for a moment, medical school is very difficult. If you think it isn't, one of the things we do on the admissions committee is that we look at roughly 800 candidates a year out of the 6,000 that apply. And we say, well, we really like this candidate. Do we think they can pass this school? Because our school, UT Southwestern, is really hard. But medical school is on the beginning. It's not the end. After medical school, you have to then figure out what you want to do, which means you have to go get a residency in something. My field is emergency medicine, or surgery, or internal medicine, or family medicine, or pediatrics, or OBGYN, or dermatology, and so forth and so forth. All the umpteen specialties that there are in medicine, you can't not specialize really anymore. And so your work ethic has to be strong. We are now in the interview season for our residents for emergency medicine. And I say, I want 3 things of a resident that we're going to hire out of medical school to come train with us. I don't care if they're Einstein. They just have to be reasonably intelligent, but they have to have a strong work ethic. Not getting toward the end of the shift, I'm not going to go see another patient. I'm tired. I'm getting off. My feet are killing me. I'm ready to get out of here. No, they are part of a strong working group in which our job is to see people and take care of them. The third thing is we're looking for nice people. We have what we call the 3 a.m. test. Elaine Reno, who's with us, I know knows this, is the resident I'm working with somebody that I want to work with at 3 o'clock in the morning in a busy emergency department who is a nice person. I would add to that, folks, that they're a nice person because they really don't use the first person singular very much. I this and I that and I this. No, they are a person who uses instead the first person plural, we. We are a team. I know that sounds corny, folks, but it's the absolute truth. And you will be interviewed very much over that as you go to professional school. Explain to me, prove to me that you are part of a team and teamwork has been part of your history. Demonstrate it to me. Tell me a time when you were part of a team and what you did and how you felt to be part of that team. And then finally, the use of the second person plural you is only to say, I am so proud of you. It's true. The third part is the commitment that you, from start to finish, you are directly involved and committed to getting through this. Next week, you're going to have a very exciting presentation by Dr. Kyle Langston, second year student at UT Southwestern, who's a really neat guy who has written a 100-page book for you about the essential elements about getting into medical school. And you won't want to miss that. In fact, he's going to put the book on his website, kylelangston.com, and he will make it available to you. It's not up there yet. It will be up. The book will be on his website this week. And then finally, if you're going to get into a medical career, it is a lifelong study. I read, Aditya, who's on the group here, he works with me, and he knows. Many of the others who work with me, Cheyenne knows, I read all the time. Folks, I've read more about COVID than I've read about anything since medical school. To get into a medical career, any healthcare career must be a commitment to lifelong study and the interest of expanding what you know. I say that if I get into a situation with a patient and I don't know something, there's one of three reasons. I either never knew it, and there's plenty of stuff I've never known, or I forgot it, and wait till you hit 69 and see how your memory's doing, or it's new stuff. And folks, the graph of new stuff looks like this. The amount of information we've learned about the immune system and the relationship of coronaviruses to the immune system alone in the last year is astonishing. So all of these together, the compassion, the work ethic, the commitment, and a lifelong scientific interest are what it takes for a path to medicine. Now, listen to me. I'm changing subjects. Look at me. You have to act like a professional. Someone will find you out if you act like an idiot. You have to be acting like a professional to get into a healthcare training program, medical school, nursing school, PA. And you have to practice acting that way, because you're asking the admissions committee to believe that you are who you say you are so far. Yes, I did teamwork. Yes, I did this publication. Yes, I did this research. Tell me about your research. I did this, I did that. We did this and we did that. And who you will be. You will have to explain about who it is you want to become. Because, ladies and gentlemen, from the standpoint of applying to medical school, you are applying for a $6 million job. I am not kidding. If you become a doc, say as a pediatrician, you may make about $200,000 a year. Let's say you did it for 30 years, folks, that's $6 million. Or if you get lucky and you become something else, emergency medicine physicians generally make around, if you work a full-time job and you see, I don't know, 5,000 or 6,000 patients a year and so forth, you're going to be making probably in a range of about $300,000 a year. These are pretty typical salaries. Times 20 years is $6 million. Now, I put these numbers, that sounds like an awful lot of money, and it is. But what I'm saying to you is that when you go to an admissions committee to tell them that you want to come to their school, you are saying to them, I want to be admitted to a $6 million job. Well, folks, at what point do you become that professional? I can't tell you the number of times that I've seen a person put a picture on an admissions committee application for their application that looks like this. Look at this. Folks, now, I'm sure that person's just fine and very intelligent, and obviously a funny, nice guy, and wants to say everything is cool. I would have worn a coat and tie or something at least quite straight. I would have made sure my hair was appropriately done. And I would be very careful, because I am asking for a $6 million job. This is a professional school, and you have to act, ladies and gentlemen, like a professional. For example, all right, right now, I want you to empty your mind, change your mindset, and you are now running, any one of you, all 238 of you, are now running the hiring. It is your job to do the hiring for a company, and you are now interviewing candidates for a $6 million job. Now, let me ask you a question. How picky would you be? Pretty darn picky, I think, if it was your job to pick the right candidate. And what if, especially, you had 100 candidates for that job, all of whom were separated by very little differences? How important would the interview be, and the quality of the application, the photograph on the cover, and so forth? So, ladies and gentlemen, if you are going to strongly consider a healthcare career, you have to become the person that you want to be. You have to visualize it, you have to work toward it, and you must become it. I mentioned a moment ago, Kyle Langston is going to be speaking next week. You really should tell your friends, and you should come. I actually have been editing Kyle's book with him. It's been an absolute pleasure. And the things that he's going to tell you next week about things to be cautious about, how to make good grades, specific techniques like the Anki technique for using flashcards, and so forth, about the various organizations, is all very helpful. And this will have to do with you getting your application and your mindset where it needs to be. Now, I'm going to change tracks. A couple of years ago, right before COVID, there was a meeting on our campus at UT Southwestern, and there was a lecture presented by one of our specialists in the admissions committee and student health student, what's actually called student promotions program. And get this, they looked at students to see if they later got in trouble with the medical boards of their state. You say, well, what is that? Once you get out of medical school and then you go to a residency somewhere, complete the residency and take the board certification in that specialty, you still can't practice medicine. You have to go to the state medical board. In this case, it's the Texas Medical Board, or wherever state that you end up. And you then have to apply for a license to practice medicine, and they will go all over your application to make sure. The Texas Medical Board is notorious for being a difficult board to get licenses through. If everything is okay and they'll go over it, you'll get your license. But if there's any questions about it, it can be very, very tough. But the Texas Medical Board also watches physicians. Physicians get complained about. For example, sexual impropriety, drinking and driving, fraudulently billing Medicare and insurance companies, quality issues in patient care. A surgeon goes in to operate on somebody's leg and cuts off the wrong leg. You say that can't possibly happen. It happens. And the list goes on. Prescribing narcotics for themselves or their family. You said, what person would go through all this stuff to get in medical school and do something stupid like that? Folks, as my old pappy used to say, human nature is what humans do. And this is, and doctors, believe it or not, are human. I know they don't seem that way. And they do a lot of stupid things. And they get in trouble with the medical board. And the medical board will absolutely investigate. All right, that was a long-winded way to say, the study we did at our university said, were there any predictors of medical students and their behavior during medical school that they would later get in trouble with the medical board once they were in practice? And guess what? There were. Being late to class, late to work, failure to complete projects, including completing projects on time. You say, really? How can that be? You mean if I'm late to show up for a rotation when I was a third-year medical student? It's what my old pappy said. People tell you all about themselves you ever want to know. You just have to pay attention. Well, the reason I was late for my shift today was, you see, there was a stoplight and the traffic was really, really bad. Yeah. Why weren't you there 30 minutes early? You say, oh, well, I didn't want to be there 30 minutes early. why should I be there 30 minutes early? Because if you're not 30 minutes early, you may not be on time. And if you're not on time, you're not there on time. And you are letting the school and the nurses and the attending physicians and your patients down. You're letting them down. What do? It's not that I'm anything special, but what do I do? I'm at work a half an hour early. Cheyenne and Aditya and some of you on the call, you've rotated with me. What time do I get there? I didn't used to, but I do now. I do it for a lot of reasons. Number one is so I can get there and have a third cup of coffee, put my feet up. I also go over the charts before I can go into the ER, so I know my patients before I go in. This is just what I do. It's neither right nor wrong. And I also want the students and the residents to see that I care enough to be there early. I also give the docs I'm relieving on shift a little bit of break so they can wind down a little bit before they go home. And I don't care, because where I work is the most social thing that I do. I'm blessed that I love going to work. I love Parkland ER. It's a lot of fun. The other part, and please forgive the first person singular about I did this. I'm just telling you what I do, because that has become part of what I think is important, to be able to demonstrate that I am devoted to this job, especially to my patients. And you say, well, failure to complete projects, including on time, that is an indicator of people's inability to put the subject that they're dedicated to first. What is that? It is medicine. Listen to me. Medicine, if you get into it, and this is all the fields of medicine, comes first. Look at me. You cannot be wrong. Do you understand me? You cannot be wrong. You cannot go into this field thinking that you're going to half-ass do something. You can't do that. You know why? Because you're going to hurt somebody. Don't you dare hurt anybody from some careless affect of you don't really care all that much. And you know what else will happen? The hospital where you're working will put you on a penalty thing because of a quality control, because somebody you were caring for got hurt, and the Texas Medical Board will get a report and they may pull your license. You say, well, I can get a license somewhere else. No, you can't. If you lose your license in Texas and you say, well, I moved to Alabama, sorry, they check with Texas about your license. If you come at this job, ladies and gentlemen, and please forgive the tone of my voice that I just used, but this is old grandpa talking here. If you come at this job with anything except an absolute full commitment to serving your patients and working as a partner in healthcare with those with whom you work, you're going to hurt somebody. And you can't do that, because medicine is the art of compassion. And I dare say that some of you, I hope all of you, said it aloud with me. Let's do it again. We're going to say it again together. Medicine is the art of compassion. Ready? Medicine is the art of compassion. My students and residents know I will never waste your time when it comes to improving the human condition. So you promised. And so, like my old daddy said, this actually is my dad. My dad was a bad dude. He flew B-17 bombers in World War II. He flew 33 missions over Austria, bombing in World War II. He almost got shot down twice. And he said, people tell you all about themselves you ever want to know. You just have to pay attention. When we look at you, ladies and gentlemen, as a future healthcare provider, what will we see? So on the admissions committee, whether it's medicine, which is what I do, or PA school, or nursing practitioner school, or some other healthcare, we want to find out about you. Can you demonstrate convincingly? Can you state convincingly why you want to become a physician? Focus here. Look at me. There are two ways you demonstrate that. Through the career you've had so far in college, which must be stated very accurately on your application. And folks, you have to be able to say it. Many of you heard our interviews that we did. I think, Michael, are you here? Michael Zine? Put your hand up in chat if you're there, Michael. and several others who were courageous enough to be able to do the interviews online in front of 300 people the other day. I thought that was amazingly courageous. So that we practice being able to state why is it that you want to do this? Can you explain in very succinct language about why it is that you want to have a career in medicine? You have to demonstrate this commitment, ladies and gentlemen. Look at me. You cannot half-ass your grades. Forgive my language. I apologize. I tend to have a potty mouth sometimes. You cannot make crappy grades and get in professional school. You can't. If you have a low GPA, you need to find something else. Why? Because number one, it has to do with you demonstrating your work ethic. It is my general opinion, if this is me, and I'm entitled to my opinion from 10 years on the admissions committee, that people's standardized tests are kind of left brain. Left is logical. and the SAT, ACT, MCAT, or pre-dental or pre-PA, these exams are very logical in nature and require logical decision-making and a very fresh mind, left brain. Whereas the GPA is very artsy-fartsy, if you will, right brain, where you can learn a subject and be able to work through a subject. But regardless, we're looking for both, that you have left brain and your right brain. Especially the right brain stuff demonstrates the work ethic with what it takes to put in good grades. If you come to us with a 3.2 GPA and applying to medical school on a system that was 4.0, which is basically kind of a medium B average, we have to be really concerned that you will be able to do the work. And folks, you've got to understand, there is an enormous amount of competition for these positions in the case of medical school, nursing school, and so forth. On a 4.0 scale, our average incoming GPA for our medical school in this July class that just started was 3.88. And the MCAT score, with 528 being perfect, was 516, which is a great score. For the out-of-staters, out of our 230 spots, excuse me, we take 10% from out of state, which is 23. The average GPA for out-of-staters was 3.94, and the average MCAT was 521. Folks, that is very, very competitive. I'll skip the MCAT since we already talked about it. That's left brain. We absolutely pay attention to that. We look at the whole person, but notice I put GPA first and MCAT score I should have put it as 1.5. We look at it for shadowing activities. We look at your applications for that, and you must be able to talk about it. This is why we created virtual shadowing, because kids is a compliment out there needed to be able to have some kind of activities of seeing what clinicians do wherever their scope of practice is. We also look for community service. We look for your social awareness, and we're going to be asking you about that. A question you might get would be, a question you may well get is, describe any unethical situation that you ever witnessed and what you did about that. For example, you might describe that you saw someone cheating. What did you do about it? Well, universities, Rice University comes to mind, but most universities have a code of ethics that you cannot violate. And if you witness someone cheating and it can be proved that you witnessed it and you did not report it, folks, you can get pulled for an ethical violation. It's true. Demonstration of teamwork, about which we spoke a moment ago. Your letters of reference are very, very important. Ladies and gentlemen, look at me. Kyle Langston's going to talk quite a bit about the letters of reference and working with professors so they know you. I have now been on the committee for 10 years, for the admissions committee. I have read hundreds of letters of reference. You want to get a letter of reference from a professor, from a teacher that knows you. I can't tell you the number of times that somebody applying to our school gets a letter that says something like this. Well, Mr. Jones said he was in my biology 300 class, which has 300 students. And while I don't remember him. On looking at the transcript, it appears that he made an A in my class, so he must have been a good student, and I expect that this may mean that he will do well in medical school. Folks, that is a non-letter. That is somebody that doesn't know you, that hasn't learned what your motivation is, with whom you have not developed a relationship. So these letters of reference are very important. And now, finally, listen to me. The interviews are very, very important. You must practice. You have to show self-control, awareness, humility, kindness. You have to know your resume very, very well and be able to explain it. If you did research, what did you do? If you mentioned a teamwork thing, tell us about that. You mentioned that this is your motivation in medicine. Explain it back to me again. Maintaining good eye contact, being pleasant. Don't interrupt the interviewer, so that in the 15 to 30 minutes you have, that you can demonstrate that you are a warm, pleasant, non-egoistic, compassionate person who is telling the truth about their application and who can state with clarity, this is why I want to get into a healthcare program. I cannot share this with you more strongly. Everyone take a deep breath for a moment. I apologize if this seems a little direct. You know, many of you have heard me talk. I did several of the first talks and a few along the way on virtual shadowing, but I truly, honestly care that all of you, all the 250 of you that are online, have an opportunity. I would really like to see you not screw something up. The things I am telling you are directly from my experience on interviewing nearly 10,000 students for our committee over 10 years, and the mistakes I've seen people make, such as this slide. Please pay attention. Folks, look at me. Don't do anything stupid, because if you do, you're not going to get in professional school. You won't get in. For example, if you get caught for a DUI, you will probably not get in your professional school, because it absolutely has to be reported. There are several reasons why you would have a DUI, but let's start with the first reason: because you drink to drunkenness. You drink to drunkenness. Each drink on an empty stomach gives you 20 milligrams per deciliter, which is 0.02 milligrams per deciliter, which is 20. We'll use it. DUI is about 80. To get a blood alcohol of 80, you would have to drink 4 drinks on an empty stomach in an hour and then get behind the wheel. And actually, since your body metabolizes 1 drink per hour, you would have to drink 5 drinks in an hour on an empty stomach to have a DUI. Now, who of the 250 of you listening would drink 5 drinks and get behind the wheel of a car? None of you. But it happens all the time. Please don't do something stupid like that. Firstly, why would you drink that much, or any other substance? I mean, there are states where marijuana is illegal, folks, and of course, other substances that are frankly illegal. If you get that on your record, it's not going to clear. You have to report it, and it's going to follow you forever. Now, yes, you could say, well, like on-campus alcohol or a substance violation. At many universities, students cannot have booze in their rooms. And so the resident assistant, who is the person who works for the university, happens to come in your room and in your trash can finds an empty beer can. That the resident assistant has to report that. And then you get an alcohol violation, which you then can explain this way. There was a get together in my room and I do not drink. I did not consume that alcohol. A can ended up in my trash can and I was accused of an alcohol violation. I know that was a stupid thing to do, and I have made amends in every way, and I assure you that I do not drink. The point is that you have to explain it. And if you have a 3.9 GPA candidate with a 5.15 MCAT who has no spots on the record, and a 3.9 GPA candidate who has a 5.15 MCAT with an alcohol violation, who's going to get in school? I don't know, but you have to think about it. Folks, getting arrested for stupid, abusive, or violent behavior, such as drunk and disorderly. We see applications that have this. Yeah, there was a fight and I was really sorry. And I took an anger management program. And now I know I'm much better and my life is targeted in such a better way. Folks, if you have issues in your life early, it is important to address them as your life advances, to look in the mirror and be honest with yourself. So I urge you to look at the slide. Don't make these errors. If you need help, get the help. There's nothing that says because someone is here, they can't move to here. I'm not saying that at all. I'm just saying, please don't put spots on your record, because anything that you end up having to write an explanation for that includes, since then, I have learned that actions matter and I'll be much more careful in the future. You don't want to have to put that on an application. Diddy, I'm just checking the audio. Was still okay?
Still sound great.
All right. I'm just making sure. I didn't hear you snore, so I guess you were hanging in there. I hope everybody's okay. I apologize if this is being direct, but not only when you're applying for a job where you'll be hopefully making a good living one day, but this issue of commitment to the care of others is not a half-assed, partial commitment. It is a full commitment. And you have to be able to demonstrate this full commitment in your life, because the medical school experience is a lot of work. You're just getting started in medical school. You have to make great grades. You have to work your tail off in medical school. And then you have to do well on what's called the STEP exam, steps 1 and 2 and 3. And then after you're doing this in medical school, then you have to figure out what you want to do with your life. You can't do it all. I like emergency medicine because we see everything. We see everything from the top of the scalp to the tips of the toenails and all points in between, whether it's heart, cardiac, whether it's pulmonary, respiratory, whether it's gastrointestinal, dermatology, whether it's infectious disease. We see a ton of COVID right now. I've seen hundreds of cases of COVID. And so in my field, we see everything. Because in medical school, you will blink your eyes, a couple of years of it will already pass, and you're going to have to declare what field do you want to be in, because you will have to then go search for a residency. And folks, how do you get into a residency? You will have to make great grades in medical school. You will have to do well on your exams. You will have to get good letters of recommendation from people that know you, who understand your commitment to that particular field. In many of these specialties, you will go do rotations, both in the hospital where you want to apply or in other hospitals or institutions around the country. You have to get good letters of recommendation from them. I hope it's clear, folks, that this is not an easy path. And then after you get trained, you have to go and hunt for a job. And I will tell you, folks, that in my field of emergency medicine, we have 22 residents per year, that the job openings were actually decreased somewhat. I can give you some background to that. There was a thought that we would never have more board certified residency trained emergency physicians than necessary to fill all the spots in the country. But what's happened is that the residency trained board certified emergency physicians have tended to stay around cities by and large, not exclusively. And so that the city positions are fairly well taken. And so that the more rural positions out in the country are where folks are tending to have to do, but the job opportunities are decreased. And you say, wait a minute, I went to college and busted my tail. And then I went to medical school and busted my tail, and I managed to get into an emergency medicine residency. Folks, for our emergency medicine residency here at Parkland, UT Southwestern, we had 1,700 applicants last year for 22 spots. If you apply to our program, you have a 1.8% chance of getting selected. You talk about competitive. I could never get in this program today. It's so competitive. Elaine, could you get in your own program today? How competitive it is. And
I mean,
so, and then after that, what'd you say, Elaine?
Oh, sorry, I had to take myself off of mute. I felt really lucky. So I matched in 2011, 10 years ago, and I felt really lucky to get into residency when I did. I went to Denver Health. And literally every day I'm still surprised that they hired me as faculty. Like, I'm like, every day I'm like looking at the like residents coming up or even the medical students, and I'm like, man, I'm glad I got in like 2011. Like, I clearly slipped under the radar. So.
And so, Jane, Elaine, I say all the time, I am so glad that I'm a faculty member in a program that I could never possibly have gotten into. So, Elaine, what do you think about all these straight and narrow kind of comments about not getting a DUI, not getting in trouble, not having stuff to go on your application that you have to explain later? Would you comment about that?
Yeah, I mean, I agree. Like, I even tell the students, like, so I live in Colorado, like marijuana is legal here, but I do not smoke marijuana. I mean, one, I'm like a horrible asthmatic, so that frankly sounds like the worst experience of my life. But two, like, it's just not worth it. You know what I mean? Like at the end of the day, like, if this is the career you want to pursue, like, then there's some sacrifices that come with it. And like, you need to respect that. And if you don't think that you can make those choices, then like, I would consider what you want to do. And the other thing is, you were talking about like how much doctors make, and it's true that physicians are really well paid, but at the end of the day, like, you should never pick this career for money, because at 4 a.m. on Thanksgiving, like when someone pages you and you're going to be in the hospital for the next 12 hours and like any holiday plans you have are over, like there is no financial compensation that is going to make you want to roll out of bed at 4 a.m. And go take care of a patient to the very best of your abilities when you're tired and you're hungry and you're stressed and you're a year and a half into a pandemic, unless that comes internally. And so if the goal is financial, like, reward relate, and that's why you're picking medicine, like there are probably 10 million easier ways to make that much money than to go into medicine, because it is incredibly rewarding, but like nobody answers that 4 a.m. page but you know what I mean?
Absolutely.
So
just mentioning then the job opportunities. But then what about taking a gap year after college? And I would say do it. Now, it's been interesting, 10 years on the committee. I would say we didn't hear people taking gap years much 10 years ago. Well, right now, many of the members of the working group of virtual shadowing are taking gap years, working with us and doing other things while applying to medical school. But if you're going to do it, listen to me. Don't just take a year off, say, well, college was tough, I'm going to take a year off and rest and just, water ski and this, that, and the other. No, you have to have a plan for a gap year. For example, taking a master's program would be one example of a plan. Or to get into an independent area of study, to do research, to work as a scribe specifically to increase your medical exposure. So if you are going to do a gap year, make sure that you have a plan for that year.
Dr. Feller, it's Gil Salazar. How are you?
Hey, buddy, you're with me.
Yes, sir. I wanted to mention something about gap years. Number one, I think there are a lot of misconceptions about this. I don't like the term gap, and it just kind of makes it sound like you're not being productive. I really prefer to call it kind of a growth year. I took a growth year, and kind of my advice for pre-meds, pre-healths is don't take a gap growth year and think that you have to do a specific type of job that's going to make you look really good on an application. If you're going to do something during that year, do something that brings meaning and value to you. It may not even be a medical job. There are so many qualities that we look for in physicians and clinicians that are kind of beyond just medical knowledge and medical know-how: professionalism, leadership, conflict resolution, resilience, teamwork. if you're going to do something meaningful. Don't kind of get roped into thinking you absolutely have to do something medical.
Great points, Gil. Thank you so much.
Yeah.
Well, please, Elaine,
Something,
go
Dr.
ahead.
I was
No,
going to
please.
say, so I did 2 growth year is actually probably a better term than gap year. And what I did actually was I did it because at the end of undergraduate, I was not sure if what I wanted to do was be a physician, and I wanted time to explore that choice. And so I worked for 2 years in a primary oncology lab, doing basic science research surrounding like specific types of uterine cancers. And 100% it made me a much better physician, because it, like, really hardcore bench research like that teaches you to problem solve, right? Because like 95% of your experiments go wrong. And you're always like troubleshooting, questioning yourself. It, at the end of the day, it made me a much better doctor. And I talked about that in, med school and residency interviews. But I actually had a student shadowing me last night in the emergency room. And she wants to go into medical school. Both of her parents are physicians, and she is taking 2 gap years, and she's actually teaching English in Spain. And I was thinking about that, and I was like, that's honestly one of the best things I could think of. So, I live in Denver, Colorado. A significant portion of my patients are Spanish speaking primarily. And so first of all, she's gaining a skill living in a foreign country that's going to help her connect better with her patients. But also, like, I being an elementary school teacher, sometimes I doubt it's that much different than being an ER doc, right? Like, you're sort of managing the waves of chaos. And I think like moving to a foreign country, like learning a new culture, like learning a new language that'll help you connect with your patients, and like learning how to manage 30 children, and getting them to learn a foreign language. That, to me, if that was on someone's application, and I don't know what you'd say, Dr. Fowler, but I would look at that and be like, yep, they'll be fine. Like,
Wait a minute, Elaine. Wait a minute, Elaine. Are you saying that in your ER, there are occasionally physicians and staff who act like spoiled brats, and occasionally you find pee and poop on the floor? Are you saying that's true?
Hopefully there's not physicians that act that way. I'm saying that, like, I don't know that elementary kids still pee and poop on the floor, but I feel like being an elementary school teacher probably involves like a bit of chaos management that is not that dissimilar to how an ER works. Like, we stay calm in the chaos, like they get to do that too.
All right. This is great. All right, let's move on. Thank you, Elaine. Thank you, Gil. All right, Didia, I can't imagine after all this dogmatic finger pointing that there are any questions at all, but I would ask also Dr. Salazar and Dr. Reno to assist me in these questions, in answering these questions, if you don't mind. So Didia, take it away.
Yeah, so for the first question, it kind of goes back to your path to getting to medicine. Did you ever have any second thoughts about going into medicine, and how did you overcome or deal with those moments?
Yeah, I'll start. I was actually in pre-law in 1970. I know that sounds 100 years ago, y'all, but it goes by so fast. And I did pre-law for a year, and I was genuinely uninterested in it. And so after a year, and actually Elaine and Gil, 50 years ago, last month was when I changed my major to pre-med, half century ago. So I know that seems forever, but the point was, I initially was not interested in medicine. I changed to pre-med. I became mesmerized with the sciences. I skipped a year of college and got into medical school early, and then I went to a year-round program for 3 years in med school, and then took a gap year after medical school and did research. And then I took a year of surgery and was genuinely uninterested in that. And then I started working ER. I don't think for me that once, this is just for me, that once I got on the path of medicine that I had any second thoughts. What about you, Elaine? Did you have second thoughts?
Sorry, I'm taking myself off mute because there's a fan running in the background and I don't want to be disruptive. I actually started as an art major. I came from like a small town in Ohio. My father has a 10-acre horse farm. And while I knew veterinarians, I didn't actually know any doctors. And I didn't want to be a veterinarian because I'm allergic to animals. And so I went into undergrad like pretty lost, and I was actually a general art major for a couple of years, and then I switched to molecular genetics because I just liked it more. And so I feel like my path was like pretty laundry, to be perfectly honest. And even after I graduated undergrad and before I got my research lab job, I was actually a cocktail waitress in a casino in Laughlin, Nevada for a summer, mainly because I needed to pay bills and I needed health insurance. And so for me, a lot of the choice was really about learning what medicine meant and what it looked like, because I didn't get those experiences as an undergrad. And so I think once I made the choice to move forward, like to me, it fit and it clicked, but I spent a lot of time making sure that I was making the right choice for me, because it wasn't something that I knew anyone who'd ever done it before. Like in my home community, like people just don't move to different states and become doctors. Like it's just not a thing that, you know what I mean? It's just not how Waynesville, Ohio works, I guess.
Right. Okay. Let's see. Aditya, let's do the next one.
So many of these students, their entire undergraduate career has been online. How would you recommend one creates a good relationship with their professors when doing classes online to get a good letter of recommendation?
That is a terrific question. And the answer is that hopefully you can use those online connections. It happens to me all the time. For example, the virtual shadowing folks, Aditya, how many kids from virtual shadowing contact us a week? 2 or 3, 1 or 2,
a lot.
something like that. So in a year, I've had dozens of y'all contact us to say, is there some kind of connection that we can do? So you can connect through online. Gil, do you have a comment on that? You still with me?
Yes, sir, sure do. That is indeed probably one of the biggest challenges of this generation for pre-health students. And so my best piece of advice, and it's about the human relationships that you build, and obviously kind of getting to know somebody in person and doing things in person is far more valuable. But I would say that in this era where you're conducting business remotely, the value that you bring to that relationship with your professor can really dictate how well that relationship can progress. So some of the most creative ways in which I've seen those relationships work is assisting the professor with various aspects, administrative, et cetera, for the class, volunteering to assist other students, for example, becoming useful in the process of developing a curricula, giving feedback. So get really creative with these folks. They really
Gil,
appreciate the feedback.
Yeah, Gil, I would add to that, say, ask the professor if there's an area of interest that he or she would like some assistance in, for example, doing references, to do some writing and so forth. And that is another way.
100%. Stay productive.
All right, Aditya, next one.
Next up, if your undergraduate GPA is low, but you do a post-bac or master's, how are these factored into the GPA calculations?
That is a great question. The answer to that is this. The lower GPA in undergrad school does not necessarily mean that you're not going to get in. What we look at and what I look at as an interviewer and as a committee member is the trend. And so let's say someone was a 3.334, but then they have gotten into post-bac where they've made straight A's and they get excellent recommendations and good letters and so forth. And what we see is a steady upward trend. A subset of that is that some people who have the 3.3 and 3.4, in fact, had issues. For example, they had to help support the family. That happens. They had a father that left, or they were ill, or they were depressed. People get depressed. That doesn't rule out the possibility that they took a semester in college where they took too much and did badly, and so that they later became more in control of their time and so forth. So there are, we definitely look at the trend of grades. Next question.
The next question up is, I'm compassionate, but I don't think that I have the confidence to be the doctor that I want to be. In what ways can I fix this?
That's a wonderful question. It starts with compassion. Along the way, parallel, it includes an adeptness to scientific knowledge. If you really just don't have the real interest in science, medicine is applied science, folks. And if you just don't have the real interest, and then along with that, the adeptness, that demonstrates that you may need an alternative path in your life. And by the way, medicine and nursing and PA is so that you can help one person at a time. Listen to me. There are plenty of ways to help people in their health and not be doing it one at a time in an exam room. Get a master's of public health. Get into a public health situation, such as working with the Department of Public Health or something similar, so that you can help thousands or tens of thousands, or in the setting of large cities, hundreds of thousands or millions of people. All the health of all those people all at once is just as important as one patient at a time in an exam room. If your heart leads you to being compassionately involved with helping people and applied science, but you don't think that the rigorous nature of medical school or PA school or nursing practitioner school is where you really want to go, fine, finish your college, get a master's, for example, in public health, and work down a path of how you can truly be involved in helping people in ways that will be on a much larger scale than one person at a time. Aditya, why don't we take one last question and then we'll get on to the second half.
Yes, sir. Could you talk a little bit about how you found a career in academic medicine and what advice you would offer to a current medical school applicant with potential interest in academic medicine?
I will tell you about the way it happened to me, and it was that the job found me. I didn't find the job, namely that I had had an initial career in private practice up until the age of 47 in my hometown in Georgia. I sold my company and thought I was going to retire. Well, a guy that I had met way back in 1984, excuse me, where we formed this EMS medicine organization, ultimately ended up at this university here. And right after I retired, he contacted me and said, "What are you doing?" And I said, "Well, at the moment, nothing." And he said, "Well, why don't you come out and take a look?" And so I came out to Texas. There's nothing not to like about Texas. There is no state income tax. Springs and falls are beautiful. Winter is that 5-minute period between fall and spring, and summer is hot as hell. So if you don't like it, stay indoors. And all the folks are Texans, so they speak American. So the job found me, and I just got lucky. It by no means has to happen that way. The most common way that an academic job will occur is that while you're in training, in residency education, the people at the university where you're training will take interest in you and say, "Don't you want to stay here and become one of our faculty members?" That is by far and away the most common reason. There are other reasons. For example, let's say you were working somewhere and you published a research article, and because that article created a stir in medicine, then a university reaches out to you and says, "Would you consider coming to our university?" So there are a number of ways. So the way I happened was more very Stephen Jay Gould, that the tape of life, if rewound, would not play the same way a second time. So Aditya, can we move on?
Yes, sir.
Folks, I figure we got about 25 minutes more to go. So I hope y'all will hang in there. Moving then into the issue of burnout, what is that exactly? And what seems to happen, remember that what medicine is, the broad spectrum of medicine, is learning and applied science so that you can be involved in the care of others. Providers, meaning physicians, nurses, and so on, excuse me, get tired of taking care of sick people. You say, "Well, wait a minute, that's what they signed up for." Well, there are so many parts of taking care of sick people. There is the documentation on the electronic medical record. There is dealing with the things that happen, in my case, in the hospital, or the billing of insurance companies. There's getting sued for malpractice, and that can happen to any one of us. And so for some reason, people get tired of taking care of sick people, and thus they stop being really interested in their jobs and lose the art of compassion, or perhaps they never really had it. We knew last year that we wanted to help folks see into the lives of physicians, nurses, excuse me, physicians, assistants, nursing practitioners, and so forth. And so we created this website as an opportunity for you to be able to see under the covers, if you will. This is 69 lectures. We have almost 130 hours of shadowing time online. We have over 46,000 pre-health students from over 1,000 universities around the world in 36 nations. And we've had this now 69 sessions. We've watched the growth of our participant sessions of people and how often they take the quizzes. Notice that we were seeing 5,000 and 6,000 people taking our quizzes. So we realized that there was a real need for online. So now to wrap up, this next session will take about 10 or 12 minutes. I'm going to offer you some direct medical tips for your future. I'm not going to yell at you anymore about not DUI and being careful and not doing stupid things. I'm going to hand you some medical tips so that you will be able to make diagnoses and not hurt people. I call them Fowler's. I know Elaine and Gil are just chuckling on this. Fowler's 15 laws of safe medicine. All of my residents know this. What is Fowler's first law? Always explain a tachycardia. All 239 of you repeat that after me. Always explain a tachycardia. What in God's name does that mean? It means if the patient is having a rapid heart rate, something is wrong with them. Well, you go, duh. Well, folks, it means you have to examine the patient. You have to find it. You have, and it's not just a tachycardia, it's abnormal vital signs. Folks, that's why they call them vital signs. The speed of the pulse, the quality of the pulse, the skin color, moisture, temperature, capillary refill time, the rate of respirations, the quality of the respirations, the status of the airway. We can add into that other relative vitals like pulse oximetry, especially in the setting of COVID, like waveform capnography, where we measure the carbon dioxide being exhaled, like blood sugar. So you can add some additional vital signs. Don't depend on the presence of a tachycardia to determine that an emergency is present. Just because someone has a normal pulse rate does not mean that they're not really, really sick. Number two, and one of my dear old friends, Dr. Oliver from back in Douglasville, gave this to me from my hometown. He said, it isn't what it isn't. It's what it might be that will get you in trouble and hurt your patient. What does that mean? Folks, you really don't develop one diagnosis. You develop a differential diagnosis, meaning after taking a history, performing a physical, doing laboratory work, doing imaging like x-rays and so forth, ultrasounds and so forth, you then say to yourself, based upon all this, I think that this is what it is. It could be this. I don't think it's this. And I know it's not that. That's called a differential diagnosis. In my world of emergency medicine, it is so more often take chest pain, take shortness of breath, take abdominal pain, that I'm not sure exactly what it is. I don't think it's appendicitis, but it could be, and so forth. And so it's called the development of the differential diagnosis. Now, listen to me. When, not if, but when you as providers develop a differential diagnosis, and there's something on the list that you haven't ruled out, and it could be, and it could hurt the patient, you be careful. Because if you're not, you're going to hurt somebody and you're going to get in trouble. You say, well, God Almighty, that makes medicine really hard. No kidding. Welcome to the world of medicine, folks. And that's why I get in early. I look at all the patients and listen to me. This is not in my laws. This is what I do. Right before I finish every single patient, I do a focused moment. Ray does, where I look at the history, the physical, the lab work, the imaging one more time, and the old chart, and make sure that that's what I think. It takes a little longer, which means that my putting patients through the ER takes a little bit longer, but I'm really, really careful because we can't accept that we can be wrong. Are you going to be wrong? Yes, but you can't accept it. You cannot accept going in that you could be wrong. We're not heroes. We do not have to prove that someone will do well as an outpatient. Oh, well, he'll probably be okay. Somebody I see in the ER, he's a little short of breath, but he's feeling kind of okay and his family's with him and he really wants to go home. Well, he'll probably be okay. Well, what if he isn't okay? We don't have to, it is not our job to prove that the patient will do well as an outpatient. Outpatient meaning going home. It is our job to be concerned that they may not do well. For example, Aunt Minnie is old. She has already fallen once today, didn't really hurt herself, but bumped herself pretty bad, and is now in the ER. I've done the x-rays and the CAT scan, and she doesn't have a fracture, and she's feeling better, and she kind of wants to go home. What happened to Aunt Minnie? She fell. Why did she fall? I'm not sure. Well, she slipped on something. Okay. Or did she get lightheaded? Was there a moment? Did she have a dizzy episode of some sort? Why does it matter? Because let's say she's 80 years old and she's frail. She's already fallen once today. What is my chief concern? Why did she fall? And will she fall again? And you say, wait a minute, Fowler, you've been in medicine almost a half century. You mean you spend your time in the ER all worried that Aunt Minnie could fall? Yes, that is my job, because if Aunt Minnie goes home and falls and breaks her hip, she will die. I can give you umpteen examples of that. She will die, horrible pain not to mention, and she will develop pneumonia, and that'll be the end of her. So it is my job to help prolong life. This is just a silly one. Folks, if it's blue, somebody twists something, they twist their ankle, they fall on their arm, and their wrist is swollen and blue, or their ankle is swollen and blue. Folks, that is broken. I don't care what the x-ray shows. You must be careful. Next one. This is, by the way, many of the ways that I've seen physicians get in trouble that have sent patients home, like this. Never send home a sleepy baby that has a fever that doesn't come to full wakefulness before you send them home. Wake that kid up. If they can, get them to walk around, make sure that they're eating and drinking and pooping and peeing normally. And if you give the baby a dose of medicine and he vomits it up, be careful. Don't send that home and a kid home until you've done a spinal tap, a lumbar puncture on that kid, and you've seen the results. Because also, once the patient is out the door, you have lost complete control of the situation. The same thing applies to my paramedics. Half the time, paramedics go to a scene, 911 call, actually no transport of the patient occurs. Once the medic leaves the patient, they've lost control of the situation. Once Ray and Elaine and Gil send a patient out the door, we've lost control of that situation. Number 7, give the first dose of medication in the ER if you possibly can. It just makes good sense to do that. Number 3, and I think this comes from the tone of this talk, be a fierce advocate for the needs of your patients, whatever it may be, clothing, food. I would ask Gil, but let's don't take the time. How many sandwiches do you give away in the emergency department all the time? Fiercely advocating for the needs of your patients. You also have to find out what the real emergency is. Why did the patient become angry? And the list goes on. But you have to really examine the patient to find out what the real emergency was. Because we have 2 responsibilities in the ER. Is there an emergency present? And if there is an emergency present, for example, abnormal vital signs, or pain, or shortness of breath, the corollary then is it a life-threatening emergency? And what is the best name you can give to the problem? Sometimes the best name you can give is short of breath, respiratory distress, and that's the best name. You can give 10 different reasons for why it may be there, but at least you have picked up the fact that the patient feels short of breath and their respiratory rate, when I look at them, is elevated, and their work of breathing, how deeply they breathe, is increased. This was given to me in the during my third year medical student year by Butch Wally, who was the senior No, I'm sorry, I beg your pardon. That would have been in 1977 when I was an intern by Butch Wally, who was the senior resident on surgery. And he said this, and folks, this is a gift. When in doubt of what's wrong with the patient, go talk to them some more. You haven't talked enough. Now, that can be especially challenging when you're having to use a translator interpreter line because the patient speaks Urdu, Arabic, Somali, or Mandarin, not to mention half of our patients at Parkland ER speak only Spanish. It can be quite difficult, but when in doubt of the patient's condition, take more history. This was also something Butch Wally said to me, which is always develop a physical exam that you trust and always do it. Look at me. Always develop a physical exam that you trust. I cannot tell you the number of times that residents and students have examined a patient who is short of breath or having chest pain, and they haven't looked at the neck veins of the patient. If someone's short of breath and I hear noise in their chest, I'm looking for evidence of volume overload in their vascular system. If you don't look at the neck, you won't see it, which means that the patient, that the provider has left out steps. The examination is a downgoing process of 1, 2, 3, and so forth, and you must do it all the time. It also means that when you do that same exam every time, and you trust the results because they've been validated by other clinicians, that if you always do that, you will trust your physical exam. What's the most common cause of tachycardia we see in the emergency room? Probably somebody using a nebulized inhaler, but could be drugs and also infections. What is the most common cause of bradycardia, slow heart rates? It's probably chemically induced and not marathon physical conditioning in the emergency department. We do EKGs, electrocardiograms, on all kinds of patients. A normal cardiogram rules out very, very little. A patient can still be having absolutely a heart attack with a stone cold normal EKG. So be careful about electrocardiograms. And finally, altered mental status, someone who is not right in responding to you, always means that something is wrong with the patient until you prove otherwise. Is it dementia or is it delirium? Dementia meaning somebody who is, some say that I'm getting their brain faculties are dimming with the advancing years, or is it delirium? For example, in fact, they're on a new drug. They've been placed on digitalis for a heart rhythm problem, and now they've actually become digitalis toxic. And this patient who is not right is actually quite sick. And so, ladies and gentlemen, as I wrap up here, that was a gift from me to you. This is posted online. You can also go to my website, rayfowler.com, and Fowler's 15 laws are posted out there, and I hope that you found that helpful. Let's take 3 or 4 more questions. We're already well into an hour and a half. Aditya, take it away. Elaine and Gil, I hope you're still with me.
Actually, Dr. Salazar has been pretty active in the chat answering students' questions, so I've asked them to toss a few more in the chat. The first one is, how is your work-life balance for emergency medicine? I guess throughout your career.
I will speak quickly, and then Elaine, I wish you would take the question also. I am a single guy with no kids who's old, and I very much of my social life is the medical part that I do. The nice thing, especially about emergency medicine, is that you can pretty well pick your shifts, excuse me, and then set up your off time so you can fairly well control your off time. Elaine mentioned, now Elaine has a family. And so Elaine, can you comment about your work-life balance?
Yeah, that's a great question. So I am academic medicine, which means I probably work more than if I was in private practice or in a small group. So the first thing I'd say is certainly it's possible. So I have 2 young children. There are a ton of physician moms. And I think something like 50% of people matriculating into medical school these days are women. EM bodes well, I think, because like you can try and really be adaptive in your schedule in terms of spending time with your family. And our schedules are really variable, which has its ups and downsides. I'm trying to create what I would define as like quality time for our kids. So we have a nanny, and then I started taking every Friday off from everything. So clinical work, like academic work, so that I can just be with the children on that day, so that we get just like mom and kid quality time. And then I work probably 50% of weekends, so it's not like I'm not working enough. But I think that there are ways to make it work, and I wouldn't not pursue a career like this if it's the right thing for you because you're worried about work-life balance. Because I mean, I think that it is achievable, and you can still have a happy family life.
And plenty, and Elaine, I think you would back this up, plenty of my colleagues have had children during medical school and during residency, and they've made it work. And so you can balance your life. Now, med school is hard work, and residencies are hard work. So just understand that there will be challenges. Gil, you want to chime in, or was that enough?
Yes, sir. I'll say that for me, work-life balance, I take an approach of being very regimented with my out of work life. And those interests are very, very small, but very, very dear to me. So I focus mostly on things that increase my physical and mental health. I'm very devoted to those things. I try not to get in 35,000 different things. So my working out is big for me. My family is big for me. My cooking is big for me. And I don't have a lot of other kind of hobbies and interests. I just focus on those three things and try to get really good at those.
Thank you, Gil. Adidia, let's take one or two more.
Next up, what do you look for in a good personal statement? And how do you show your compassion and work ethic in your personal statement?
That is an absolute great question. I've read hundreds of them. First, the personal statement needs to be well written. Don't begin every sentence with, I did this and I did that, and after that, I did this. That's crappy writing. You want to actually write well. Now, sometimes they're kind of funny. I had one write in on a personal statement one time. I've wanted to be a doctor ever since I was inside my mother's womb when she was pregnant with me. Well, it's kind of cute, a little far out. What you want to do is be able to express, it needs to be well written, which means good grammar, which means pay attention to subject verb agreement in your sentences, use punctuation appropriately, have someone you trust or several someones you trust read personal statements so that the grammar can be corrected, the flow of it, and so forth. You'll be amazed what you don't see in your own statement. Number two is you have to be able to be in touch with what has drawn you to a career in medicine. Again, medicine is medicine, PA, nursing practitioner, and so forth. And be able to state that. I have read many personal statements that said, my motivation to medicine was really when my younger sister had a hangnail. And after that, I knew I wanted to be a physician. You go, really? It was a hangnail or a pimple on one of your relatives, and that's the reason you want to be a doctor? That doesn't tell me very much at all. You have to be able to look inside, which means you have to think about this and be able and write it down. Get a legal pad and a number 2 pencil. I know none of y'all have held a pencil probably in your lives. And write this down and critique it, edit it, so that you can be able to express in nice flowing paragraphs the reason why you want to be involved in the lives of other people. Let's take one last question and then we'll call it a night.
Okay, one last question. So this student, I assume, is referring to writing a personal statement or something of that sort. It says a lot of the motivation for going into medicine is the mistreatment, perhaps too strong of a word, that he or she has received from our healthcare system. And unfortunately, a few doctors and I have been told to, so she's been told to be careful with this sort of question because mistreatment that she's received might be too strong in terms of bad-mouthing doctors.
Yeah, that's a great question. And I see this in personal statements. And when occasionally I help folks edit theirs, you never want to get accusatory in a personal statement. I am here to correct the mistreatment that's happening to so many people. Well, in that statement, you have just said, those doctors are not taking care of those patients right. Well, you're not even a clinician yet. Who are you to say that? You don't know. And there's so much involved in the care of patients. For example, How much did the patients take care of themselves? There was a stirring article in the New York Times yesterday online. Michael Barbaro, who does this online sort of what's happening kind of session. And this had to do with folks in nursing homes who there with dementia being heavily medicated with psychotropic medications like Haldol and other things that sedate them. And basically they lie around the bed and over time they just fade away, lose weight and pass away. You know, I understand that and it's concerning. You're also not in there in the nursing home. It talked about one patient's family who placed grandpa in the nursing home, and he gradually went downhill and eventually passed away. But he had been medicated with psychotropic medications. And the statement that the person said at the very end of this interview with Michael Barbaro she said, well, if I'd ever known that they were going to give him those medicine, I never would have put him in there in the first place. He only had dementia. Well, that raises a lot of issues. I'm not critiquing or criticizing those folks in any way, shape, or form, and I'm sorry for the loss of their family member. But you don't want to be accusatory. You don't want to make statements that you can back up, the statements that you cannot back up. Everybody knows that. Or the largest problem today in medicine is, you know, these are statements that would be very hard to back up. They are grandiose. And I think that they would be read in a negative way by members of the admissions committee. Well, all right, ladies and gentlemen, what kind of an evening have you had? Aditya, you want to begin to wrap up?
Yep, sounds great. So here on this slide, you can find all of our links in terms of our email, our Instagram, social media, YouTube. This recording will be up on YouTube shortly after we conclude. And feel free to reach out to us on virtual shadowing if you have any other questions that didn't get answered tonight. Next slide, please.
And before I go to that, and I want to thank you again for all of you coming. If I was awfully dogmatic and pointing a finger a little bit too much, I hope there weren't those of you who felt I was being insensitive. What I'm truly hoping for each and every one of the 250 of you tonight that were on this program is able to find the healthcare career of your dreams. What I'm simply trying to do is, having been around and seen a lot of people get in trouble or a lot of people work hard and not make it because of various things, to try to help you direct your path for the highest goal of meeting the goal of success. So again, Aditya and the working group and Dr. Salazar and Dr. Reno, both part of the working group, we want to say thank you so much for coming. We'll be back here next week. And Aditya, you want to tell them about this?
Yes. So for tonight's session, you be sure to complete the assessment using this QR code. I'll also toss the link in the chat a few times so that you can take this quiz. You need a score of 70 or higher to earn a certificate for completion of this verified hours. Make sure that you download that certificate for your own records. Thank you.
So folks, thank you for coming. On behalf of the whole working group team who works every week to put these things together for you, we were so glad that you could come, and we look forward to seeing you next week. And on behalf of the whole working group, we wish you